Good evening, one and all. A few words about Dr. Saravanakumar. He is working as Associate Professor of Anesthesiology, Government Tiruvallur Medical College and Hospital, and his areas of interest are USD guided regional anesthesia, neonatal central line cannulation, airway management, and PG teaching. Welcome, sir.
Thank you, madam.
Thank you, sir.
A very good afternoon, one and all. At the beginning, I would like to thank Professor Edward sir and his team for giving me this wonderful opportunity to stand before you. And my topic would be to brief the postgraduates on regional anesthesia and peripheral nerve blocks. So, what is regional anesthesia? Is defined as the temporary removal of nerve conduction and pain senses in certain regions of the body with local anesthetic medications without causing loss of consciousness. So that is how regional anesthesia is defined. So going back to the history, the term regional anesthesia was coined by Harvey Cushing, who rightly said, it always works provided you put the right drug at the right dose in the right place. So that was his famous words. And it all started with Carl Kohler. You all know that how he put cocaine in the eyes and how the era of regional anesthesia was born. And at the same year, Halsted, a famous surgeon, applied cocaine to the brachial plexus, and brachial plexus anesthesia was started in the year 1884. Then gradually it progressed, and in 1898 August Bayer did the first spinal anesthesia. Although Corning did it first, it was successfully done by August Bayer, and 20 years later we started having epidurals. And then the revolution started once we had an improvement in the quality of the drugs we got. So cocaine was very toxic. So safer drugs came, the technique flourished and has reached to the present state. So we classify regional anesthesia into three types. Basically neuraxial anesthesia, which includes spinal epidural or combined spinal epidural and caudal. We do peripheral nerve blocks, which can be blocking the plexus or individual nerves. And then there is intravenous regional anesthesia, commonly called as Bayer's block. So this is how we classify regional anesthesia. So before doing the practice of regional anesthesia, you must surely know where not to do it. So what are the absolute contraindications for regional anesthesia? So the absolute is patient refusal. The patient says no, it stands no, and do not ever attempt it. Then the patient has a history of allergy to local anesthetics, where history taking is very important. And if the patient is having an infection at the site of needle entry, these become absolute. Relatives are the patient is having a coagulopathy, pre-existing neurological deficit, systemic infection, and mental illness. This can be slightly changed, the relative contraindications slightly change depending on what block you are doing to what situation. So you must be aware of that. So there are certain pre-procedural concerns before doing a regional block. What are the things you must look into? So everyone wants the block to work or the neuraxial procedure to be successful on the first attempt. But in that hurry, you should not overlook the side. So always confirm the side. So we use the mnemonic slim rad. You can see the S stands for the side. Then L stands for light. If you're planning an ultrasound guided block, get your machine ready. Always have an IV access. Connect monitors. Resuscitation drugs and equipment should be mandatory, and no matter how good you are, you should have an assistant with you to help you with the block. Then general anesthetic agents, and along with that you should have intralipid. Now recent guidelines say that the intralipid should be available whenever a regional block is given. So knowing about the equipment, what you're going to do. So for example, you're planning a spinal anesthetic. So the very important to know what equipment you're going to use. The most common is your Quincke Babcock spinal needle, what is shown. It has a cutting tip, and the other common is a Whittaker or a pencil point tip with the opening 2.5 mm behind the tip, which produces less spinal headache. So please choose when you have taken needle in your hand to do a neuraxial block, you have to know what equipment it is. So what size it is, because the size is important when it comes to a post-dural puncture headache. So finer the needle, lesser the incidence of headache. So the color coding is there. So you, as postgraduates, especially in the first year, you must know which color code belongs to which size of the needle. It is always advisable or preferable to start with a 23 gauge once you start learning. Then as your experience increases, come down on the size of the needle, like 25, 26. These are standard wire gauges. As the gauge increases, the size of the needle decreases. So first year postgraduates generally advise that it is better to do a single puncture with a 23 gauge needle rather than doing 6 or 7 punctures with a 25 or 26 gauge. So have that in mind. Then epidural, we commonly use what is called the 2E needle with the Huber point. The 2E needle is an 8 centimeter needle which has wings, which helps you to identify and reach the epidural space with your grip. And the tip is, you can see the tip is slightly bent. It's called the Huber point, so which allows the catheter to be placed in the epidural space. So next is the epidural catheter. The epidural technique is a gold standard for labor analgesia. So at some point of time you have to be proficient. So once your spinals get better, then you slowly have to move to an epidural. Epidural is an advanced technique. You have to have that in mind. Once your hands are trained and you start feeling the ligaments where you breach with a needle, then you can move on to the procedure of epidural catheterization. So you have to know the catheter comes as, it's a nylon catheter with markings. So it has you have to place it very aseptically, and removing the catheter should also have concern, because if the patient is on anticoagulants, on heparin, so inadvertently if you pull it, it can produce a vertebral canal hematoma. So all these things you should have in mind when you are handling these equipments. The other equipment to help you do the nerve block is the electrical nerve locator. So from Cushing's words, if you want your block to work, you should precisely locate the nerve. So how do you do it? First we were doing, or we are still doing with what is called an electrical nerve locator, which delivers a current for a specified period of time, say 100 microseconds, which we call it as chronaxy. So for that time the current of say 0.5 to 1 milliampere is delivered. If your needle tip is close enough to the nerve, you will get a evoked motor response. Then you will know you are very close to the nerve. If you are too much into the nerve, even very minute current like 0.2 milliampere can trigger a response. In that case, you know you are actually inside the nerve where you should not be. So this enhances your precision and also acts as a safety. Usage of electrical nerve locator for regional anesthesia. The next is ultrasound, the machine which revolutionized regional anesthesia. Blocks which were never thought would happen, or certain procedures which would have never been imagined are now being easily done because of ultrasound, because of this imaging where you are able to see the nerve and block it. So you must be also able to know what probe or the transducer which you place on the patient's body. The convex probe is used for blocks which are deep inside. Linear probe is used for superficial blocks. Of course, the cardiac probe we use it only for focus, but the most common probes used are the convex and the linear. Then now come the echogenic needles. Now guidelines have started saying that you should use echogenic needles to improve safety because the visibility is better. But of course it comes with a cost factor. But you should know that now we have specific echogenic needles which make the procedure much more safer, so that you don't injure the nerve. So why ultrasound? Direct real-time visualization of the nerves. You can accurately place the needle. You can depict the surrounding structures and the muscles. If there is an anatomical variant, you'll be able to pick it up. And ever since its use, the amount of drug you deposit there has significantly come down, so reduced risk of toxicity. And of course, you don't use a C-arm, so there is no ionizing radiation as in a C-arm. So very safe to use. So basically, you are using sound waves of high frequency to image the nerve. So it's absolutely safe to the patient. So this is the advantage. So when I place the probe, I can see what are the structures. You can see the plexus is here. I'm going to place my needle here. What are the structures I'm not going to hit? The pleura is here, the subclavian artery is here. So everything is seen. And usually the supraclavicular, from the upper trunk, you have the suprascapular nerve which comes here. So it's in my needle path. So I know I should avoid the structure. I will navigate my needle to come to the brachial plexus. So usage of ultrasound greatly enhances safety. So that's why you have to, while you're training, you have to study about the basics of ultrasound. Keep looking at the screen to make your eyes get familiar with the image you see. So as I told you, see, this is an upper trunk block. You can see the needle tip being placed close to the upper trunk but not inside the nerve. And once the block is done, if this is supraclavicular brachial plexus block, you can see the block, the local anesthetic surrounding the plexus, or the plexus being bathed by the local anesthetic. So now you know that you have done a good coverage, you can stop that. So what volume we were once giving, like 35 to 40 mils, you have now come down to say 15 to 20 mils. So it's a 50% reduction is achieved. The next, moving on to the drugs which are going to use. Basically there are two classes of drugs. One is the ester and the other is the amide. So esters, the first one was cocaine, and now the commonly used or only in use is chlorprocaine. So chlorprocaine is a very short acting ester. But the problem with esters is that they are prone for allergy. So the more commonly used drugs are the amides, starting from lidocaine, first introduced in 1940s. Now we most commonly use these two agents. Bupivacaine is still in use, but more safer than bupivacaine are ropivacaine and levobupivacaine. The chance of toxicity is significantly reduced. Amides are linked with toxicity, local anesthetic toxicity, but since the introduction of ropivacaine and levobupivacaine, they are considered safe. So this is the structure. So please remember, as postgraduates, you are going to deal with only few drugs. It's always better to know the structure of the drug. So the aromatic part and the amino group are common to both groups of drug. Only the intermediate chain decides whether it is an ester or an amide. So this structure. So by looking at the drug structure, you must be also able to identify whether it is an ester or an amide. The local anesthetics are also classified on basis of duration. So why it is important? You want to know the duration of the surgical procedure. So what agent to choose? So low potency, short duration, procaine, chlorprocaine. So what determines the duration? Pharmacokinetics, protein binding. So drugs with low protein binding act shorter, procaine, chlorprocaine. Whereas drugs with a longer protein binding, larger protein binding, say bupivacaine with 95% protein binding, act longer. So for longer duration surgeries, for regional anesthesia, we either choose bupivacaine or the more safer ones, levobupivacaine or ropivacaine. So this is how they act. They act by sodium channel blockade. So it is not directly over the surface. What happens is when you inject the drug gets past the membrane inside the axoplasm, then gets protonated. So it gets the hydrogen ion, gets ionized, and the ionized agent blocks the inside of the sodium channel, so that the action potential cannot be propagated across this nerve. So what is the catch here? So a drug, all local anesthetics are weak bases. Remember, weak bases. So when you are injecting into the tissue, they are unionized. But once into the axoplasm, they get ionized. If the tissue is acidotic, where there is a lot of protons, so the moment you get inject, they get ionized. So they cannot cross the axonal membrane into the axoplasm. So if the tissue is acidotic, for example in a diabetic foot, however try to you give a drug very close to the infected area, it is not going to work. It is because of this reason. So you should have this in mind. So next, when you give a large volume of drug, there is always the risk of local anesthetic toxicity. So all these amides which we commonly use are cleared by the liver. There is a ceiling, so it cannot clear very fast. So what happens if you give beyond the particular dose, the patient will start having toxic symptoms. So how does the symptoms start? Initially as perioral numbness, tinnitus, metallic taste, the patient becomes garrulous. What is garrulousness? Repeated talking, continuously talking. So that's a subtle sign that his inhibition, central nervous system inhibitions are going, which means that the drug is just too much for him. Then slightly it progresses to agitation, restlessness, muscle twitchings and seizures. The CNS is suppressed, the inhibitory pathways are suppressed. So it can result in convulsions. Finally, the cardiovascular system gets involved. So patient goes for bradycardia, tachyarrhythmias, hypotension, finally cardiac arrest. Remember, drugs with high protein binding bind to the cardiac proteins very well. So, and it's very difficult to revive a cardiac arrest caused by an intravascular bupivacaine. So, please have it in mind. So, this the chart which correlates serum concentration, as the serum concentration rises, you can see the spectrum of symptoms that are right. So, at the 24, you develop cardiac arrest. So, before that, coma ensures. So, your idea is to pick up the complications better. So, the communication skill while performing a regional anesthetic technique in communicating with the patient is very important, so that pick up that subtle signs even before a big symptom develops. Coming to the timeline of complications. When do these complications happen? See, less than 1 minute 26%, in 1 to 5 minutes 22, and within 6 to 10 minutes 10. Almost 60% or 65% happens within the first 10 minutes. So never leave the patient unattended immediately after the block. Now in most places block is not done in the theatres, it is done outside the block rooms. You do the block, the patient is comfortable, he says my arm feels numb, so you go inside to look at the next page, the patient is getting operated, the closure is going on, so you go inside. Never do that. Never let a blocked patient unattended to. So this you should have it in mind. So most complications happen within the first 10 minutes, remember that. So the treatment is, the mnemonic is ACLS SLE. ACLS stands for you start your advanced cardiac life support immediately, but the catch here is you use a low dose epinephrine, not your standard 1 milligram. You use 10 to 100 mic boluses, and ventricular arrhythmias are treated with amiodarone. Seizures are controlled always with benzodiazepines, and the most important thing is lipid emulsion. Unless there is a serious toxicity, it's very difficult to revive the patient unless you use 20% lipid emulsion. And the final thing is to support the heart till the drug is washed out, you may have to use ECMO. Next, anatomically what your knowledge should be more on, you should read about dermatomes. So you should know which dermatome is going to get anesthetized. For a particular surgery, if you want to do a regional procedure, you must be very sure that what dermatomes have to be blocked. So based on this anatomical knowledge only, you will be performing the block. For example, if you are planning an epidural, which can be done anywhere across the neuraxis. So you must be specifically knowing which dermatomes you have to block, so that you can keep your needle in alignment with that particular dermatome. So you would have had a class in the morning about anatomy. As I told you, before doing a spinal anesthetic, we advise every postgraduate to have a look at the skeleton and the individual vertebra. So you must know the various parts of the vertebra, and the spinal cord and the vertebral column, you must know the natural curvatures. So when you have a three-dimensional orientation in your mind, navigating the needle to the target becomes easy. So please spend some time looking at the vertebral column even before you start to practice or involve into spinal anesthesia. So spinal anesthesia is the most common regional anesthetic technique that every intern or every resident does. So it's also called the subarachnoid block or the intrathecal block. You're depositing the drug in the subarachnoid space into the cerebrospinal fluid. It acts on the nerve roots and the spinal cord. It's absorbed by vascular absorption, and the sympathetic block, analgesia, and motor block is produced. With a small amount of drug, you can produce a dense anesthesia. So it can be done in any position. Commonly the fetal position or the lateral position in jackknife you call it, or even in a sitting position. It all depends on the comfort of the patient, comfort of the operator. So you can decide. There is no hard and fast rule that it should be done only in sitting or lateral position. It can be done in any position. And what factors affect the level? The most important thing you have to remember is the dose and the baricity. So remember the amount of drug you give, the dosage of drug that is deposited into the central nervous system directly decides what level is up. And higher the dose, higher the level, so more is the complication. So you know to what level the surgery is, you have to decide and deliver only that much of drug into the central nervous system. And advanced age, pregnancy volume, CSF volume. See, as Madam told, pregnancy, the pressure in the CSF is high because of the epidural engorgement. So what happens, even a small amount of drug you deposit produces a greater extent of blockade, resulting in more complications. Always have that in mind. And patient position. So if you are using a hyperbaric solution, which means the solution is heavier or it's more specific gravity compared to the spine CSF. So the position becomes important. If you give a head down, the more drug ascends and more segments are blocked. So if you use a hyperbaric solution, immediately post block, what position the patient in is decides the level of anesthesia. So you have to have all these things in mind. So complications related to needle, related to the physiological response and related to the drugs. So common is hypotension, shivering. These are complications related to the physiological changes. If your higher fibers are blocked and hypotension is not treated, can result in cardiac arrest. Needle, the most common is a post-dural puncture headache. If you do an epidural, accidentally you puncture the dura, there's more chance, the theca is breached, there's a more chance of headache. And if you add an additive, say morphine or buprenorphine, or additive you add, patient can develop pruritus, nausea and vomiting. So these are the complications you have to have in mind before you perform the spinal anesthesia. And epidural space. This is a technique slightly more advanced compared to a spinal anesthetic, where you stop before puncturing the dura. In between the ligamentum flavum and dura, there is a potential space filled with nerves, vessels and connective tissue. The nerve roots have to pass through the epidural space to come to the intervertebral foramen. So you block the nerve roots there. So the epidural space is widest in the lumbar. So practice when it comes to epidural, do it first at the lumbar level, where it's slightly easy compared to the cervical and thoracic levels. Cervical and thoracic levels never do without supervision. So lumbar you learn, you get your expertise is increased, then move on to the higher levels. So how do you identify the epidural space? Two techniques commonly used. One is the loss of resistance, where you connect a frictionless syringe to the needle hub, give constant resistance, and once the needle tip goes into the epidural space, the plunger freely moves in. Or you can place a drop of fluid on the hub of the epidural needle. Because of the negative pressure, it is sucked in. So this is the comparison between epidural and spinal anesthesia. You must remember that you give a higher drug dose for epidural, but the quality of anesthesia is much better in a spinal anesthetic. Biggest advantage is that you can place a catheter, epidural you can place a catheter and you can redose the patient. Even though we have continuous spinal catheters, they are not commonly used, but epidural catheterization is a very commonly done procedure. Then the most common pediatric regional anesthetic technique is a caudal block, where again it's an epidural technique, where you do it by breaching the sacropoccygeal membrane. The fifth sacral lamina fails to fuse in the midline. So that is covered by a ligament. Once you pierce the ligament, you are into the epidural space. So this is commonly practiced in children, because in children the landmarks are better. So it can be done landmark based or under ultrasound guidance. So the challenge, all patients, you do not get the landmarks are not easy in all patients. Very likely you are going to get obese patients or patients with kyphoscoliosis, where ultrasound comes to your help. Routinely what we do is, if you get a patient with a challenging spine, we do a pre-procedural scan to find out where the dura is, how to orient your needle, and then you do the procedure, it becomes relatively easy. It's not a very difficult technique to master, but once you start looking at the images, you'll be able to grasp it better. Moving on to the peripheral nerve blocks. Again, it's a technique where you deposit drugs into near the plexus or individual nerve. Stimulus is blocked, similar to a nerve block, where the sodium channels along the plexus or an individual nerve are blocked by the local anesthetic, and it is appropriate both for inpatient and the outpatient setting, where the analgesia can be extended into the postoperative period by placing a catheter. So the block performance can be either landmark based. So you have to read your anatomy well. So once you know your anatomy, you can, based on that, we start. But the most important thing is you have to use a guidance. Either it can be a nerve locator or ultrasound, or you can use both. Now, a deep block like a sciatic nerve block is usually done under dual guidance. You use a nerve locator along with ultrasound. And always the most important thing, when you use a high pressure to inject the nerve can get damaged. So now we also have something called an injection pressure monitor to monitor what pressure you generate while doing the injection. And it can either be a single shot or a continuous block if you place a catheter. So the commonly done peripheral nerve blocks are displayed here. So usually you start with doing the brachial plexus supraclavicular. That is a very common thing for the postgraduates to start. You read well the brachial plexus, the position, where exactly the plexus lies. Then your anatomical knowledge should be very, very high before even you start practicing these blocks. So individual nerves, when some of the blocks get spared, you can supplement by doing individual rescue nerve blocks. And now the truncal blocks are also popular. Epidurals are being replaced by the serratus plane scanning for breast surgery we are doing. So this is an example for a lumbar plexus block where you are focusing on the lumbar plexus is stimulated, you are looking at the contraction of the quadriceps. So that is an evoked motor response. Once I know with this 0.5 milliamps I am getting a response, I know that my needle is close to the nerve. And this is an example for an upper trunk block. So once I know where the upper trunk is, I look for the phrenic nerve, and so you can see I am doing an upper trunk block. This is an anteskeletal muscle and the phrenic nerve is somewhere here. So the advantage of using ultrasound during a peripheral nerve block is that you can very well avoid the You know the phrenic nerve is there, your needle tip is nowhere near it. So this is the advantage. So these are the advantages of peripheral nerve blocks: reduced postoperative pain, early ambulation, so less PONB and less sedation. The patient is awake, so you don't have to deal with the airway. These are the complications. Nerve injury is a disastrous complication, so please be careful. And beyond surgical pain control, what are the uses? Post-op analgesia, trauma and emergency medicine. Now, not only anesthesiologists are performing nerve blocks. Nerve blocks are done in the emergency. So the patient comes with acute pain following trauma, an old lady with a fractured hip, whose BP is spiking. The emergency physician performs a nerve block at the emergency room itself so that the stress response is alleviated. Chronic pain management, rehabilitation, physical therapy, diagnostic block. When you suspect this is the source of pain, you give a block, and if the pain goes up, then you can plan a definitive procedure. Cancer and palliative care, psychiatric and neuromodulation applications. So regional anesthesia extended way beyond the routine sphere of our usage. So you have to be very well knowledgeable about it. So because the scope is keeping on expanding. A new term called this is a new acronym, WSNB, at least to me a couple of years back. What is that? Wrong-sided nerve block. So it might sound a little far-fetched, but this is a very disastrous complication if it happens. So make sure that you do all things correct before performing the nerve block. The most important thing is who surgical safety checklist. Make the safety checklist and then do the block. This you should be always aware, even however experienced you are, in a hurry when you do or when there is less communication with the patient, then you can end up with a wrong-sided nerve block. So last, a small point I need to add about bias block is intravenous anesthesia. Although not commonly practiced, it involves isolating an arm by a tourniquet above the systolic pressure so that it's isolated from systemic circulation, injecting a local anesthetic into a peripheral vein so that the arm goes numb. 20 to 25 ml of 0.5% local anesthetic lignocaine is used, and it acts only for 40 to 45 minutes. But if the integrity of the cuff is lost, it can result in serious local anesthetic toxicity. So not practiced commonly, but you must know about this. So the future is, what is the future? Robotic, the surgeons are doing robotics. We anesthesiologists also are moving into robotics. Robotic assisted ultrasound guided anesthesia is coming up. So we have to keep, you have to keep learning at a very fast pace to catch up. And this is the professional competency. As far as anesthesia practice is concerned, you should know anatomy, pharmacology, physiology, then the anesthesiology component which is able to give the rescue analgesia if something goes wrong, decision making, communication skills, and finally research and development. These are these all areas where you have to focus as a whole when you grow. And finally the 4 E's. First you read, education, you study well, get qualified, then get expertise, seasoned practice. What is that? No, not monotonously doing, discuss with your peers, discuss with your seniors, what can be done differently. Teaching, the most important way how someone can grow. You teach your junior colleagues, it will help you in your growth. Then how do you get excellence? Research. When you do research, you get excellent. And finally you can go to the last E, eminence. So it's a step, it's a progress, it's a journey. It's definitely not a sprint. From the first E to the last E, you cannot jump. It's a marathon. You have to slowly progress. Keep moving towards your progression. So with those final words, I come to the end of my presentation. Thank you very much. Thank you very much.
I request the chairpersons to honor Dr. Saravanakumar sir.